Good afternoon, everyone, and welcome to What's Up, Doc. My name is Tia Teriak, and I'm a member of the Concord Hospital Trust staff. What's Up, Doc is a monthly lecture program put on by the Concord Hospital Trust. And at this time, we'd like to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up, Doc. The Walker Lecture Series was established here in Concord in 1892 from the bequest in the will of Abigail Walker. Per the terms of her will, the Walker Series offers lectures on history, literature, art, and science, as well as offering dramatic, musical, and literary performances throughout the year. All events are free to the public and are held at the Concord City Auditorium. We encourage you to check out their website at walkerlecture.org and view their calendar of programs for this year. We hope everyone enjoyed a wonderful holiday season. Kicking off the new year for What's Up, Doc is Dr. Matthew Gibb, Chief Clinical Officer for Concord Hospital. Dr. Gibb's presentation is an introduction to Concord Hospital's Cardiovascular Institute. Dr. Gibb will provide insight into the highly skilled specialists and the latest technology available right here at Concord Hospital Cardiovascular Institute. I do want to share just a few things about Dr. Gibb. Dr. Gibb attended the St. Louis University School of Medicine, and he completed both a residency and a fellowship at the Naval Medical Center of San Diego. Dr. Gibb served in the United States Navy, in the Navy Medical Corps from 1983. Sorry, Dr. Gibb.
Can I do this laying down?
1983 to 1994. From 1985 to 87, Dr. Gibb served as senior flight surgeon at the Naval Air Station in New Orleans, Louisiana, earning the award of the United States Navy Flight Surgeon of the Year in 1986. Following his service in the United States Navy, Dr. Gibb joined Carle Clinic Association in Urbana, Illinois, one of the nation's oldest multi-specialty group practices, which comprised of 350 physicians practicing in over 50 specialties. During his tenure, Dr. Gibb served in numerous roles, including chairman of the Board of Governors from 2004 to 2010. From 2010 to 2019, Dr. Gibb was with the Carle Health System in Urbana, serving first as medical director for the Carle Heart and Vascular Institute, and then serving as executive vice president and system chief medical officer from 2014 to 2019. In 2019, Dr. Gibb joined Concord Hospital as our chief clinical officer, and we are certainly very thankful he did. Please join me in welcoming Dr. Gibb.
Going to approach this as a fireside chat, not so much of a lecture, and maybe we'll have some conversation, questions and answers. And I guess I'd first say I've just going on 2 years here at Concord Hospital, and what an incredible organization. I'm thrilled to be here. It's been quite a great time, but some new twists with COVID, and now 2 years of COVID. So that's encompassed almost my first 2 years here. So that has definitely been something to reckon with all of its consequences. And it has, I just say at the outset, what I would like to talk about around developing the Cardiovascular Institute is a really, I think, great opportunity. But COVID and then more recently some staffing shortages, have affected our pace, no doubt. And so I would just mention that up front, because I know as patients look at this, some of the things I want to say and emphasize are not yet optimized because of our journey with the COVID experience. So the second thing I'd like to say is that we're approaching here at Concord Hospital our mission as a patient-first mission. So we are working in all areas, this being just one of them, to try to design our workflows, our access, and our ability to provide care from the patient's point of view. And interestingly, over the history of recent American healthcare, you might think that's intuitive, but it really isn't. It's a lot of design in our healthcare delivery has been a design around us, the people that provide care, and the efficiencies that we see best, but not so much asking what does the patient see, what could be improved from the perspective of the patient going through the system. So to do an institute model like the Cardiovascular Institute is a great opportunity. Here it was a clean slate to start looking at what are the things that need to be improved, how can we design that better, how can we get input in order to create those patient-first concepts as we design our workflows. And that was the main impetus 2 years ago to begin discussion about a Cardiovascular Institute model. And that discussion was born out of some analysis through a consultant that looked at the current state of our cardiovascular care delivery and identified some fundamental things that we could improve on. And I'll list a couple of those. One is just basic access to services, so making sure that we were as efficient and as intentional as possible in terms of our availability at the consultative level, at the diagnostic testing level, and at the procedural and surgical level. And so that was shown to be, all of those had areas that we could improve on compared to benchmarking that the consultant helped us do for others that had best practices environment in cardiovascular care. And then the next thought was around what are the resources that we have in Concord Hospital, and as now that we've come together with our partners in Laconia and Franklin, what do we have that we need to optimize that we already have, and what do we need to add, and how do we do that, and how do we grow? Because we have an underserved market in cardiovascular care here in the local area, believe it or not. And when you look at outcome data for the population in New Hampshire, our cardiovascular outcomes are not as good as they could be. So we have, I think, a mission obligation as deliverers of healthcare services to marry up what's going on in our communities and in the population at large, and try to understand gaps in care that we might be able to work on as a healthcare system. So the Institute model creates an efficient environment in order to begin working on all of those elements. The second point I'd make is that vascular disease is, I guess, ubiquitous. So patients that have heart disease often have blood vessel disease in other parts of their body, whether it's the aorta or the leg arteries or the kidney arteries or the brain arteries. And we have a number of specialties that work with vascular problems, and they're generally oriented toward parts of the body. So we have cardiology with the heart, we have vascular surgery with non-heart related blood vessels. We have interventional radiology, which does a spectrum of procedures that really provides access to the body for many different types of both therapeutic and diagnostic things. And then we have our surgical colleagues in cardiac surgery who are dealing with the heart and also the aorta and the major blood vessels. So in isolation, each of those specialties works as they're trained, and in the disease processes they're trained to treat. But in the cardiovascular world, there's so much overlap that one area may identify another problem in another part of the body that needs attention. And then in a traditional model where you have all of these specialties practicing somewhat in a silo, you end up with a lot of back and forth movement for a patient. So I'll give an example. I'm an interventional cardiologist, and I may see a patient who has a heart attack, and as they are evaluated, I might find they have an aortic aneurysm, or I might find they have kidney dysfunction and vascular disease of the kidney. So in the old school way of thought, I would take each one of those problems I found that I don't treat, and I would say, you need to see the vascular surgeon, and you need to see the nephrologist, and you need to see perhaps a cardiac surgeon. And though they would do their thing in their orbit, and then I generally get a report back, often not a verbal interaction, that says, this is what we think, this is how we'd approach it. And all of these things would go on in their own little spheres. In an institute model, we bring co-location of our specialists and co-location for the patient, so geographic co-location. So by bringing the major specialties, which are the cardiology specialties, cardiac surgery, vascular surgery, and interventional radiology, into the same physical environment, we can create synergies for the patient. So if I now have this same patient, I don't write a consult in the chart and hope that it gets done with somewhere in another building or another health system. I can walk across the hall to my colleague and say, hey, I've got this issue, and these are 3 things in this one patient that we all overlap on, and how can you help me? And for the patient, that also provides synergies, because instead of multiple visits in multiple different practices, we can accomplish often a lot more in one physical visit to our health system. So one example of that is work we're doing to do an integrated vascular clinic, where we take patients with these common problems in multiple specialties, and we bring all the specialists together in the same clinic, so that all of these things have a common time point in how the physicians get together and evaluate the patient and talk about the best care plan. And an example of that would be a patient that has both heart artery disease and peripheral vascular disease, and might have a spectrum of different options from catheters and stents to surgery to treat the whole constellation of what's going on. And they all have their different risks and benefits and success opportunities. And to be able to do that as a team in the same clinic, with the goal being the best care of you, the patient, is pretty powerful, because we don't ordinarily get to do that if we're all practicing in different locations, and we're just in our mind dealing with the only thing that we do as a specialist, not so much what everybody else can bring to the table. So we have begun developing that integrated vascular clinic, where we bring cardiology specialists, vascular surgeons, and interventional radiologists together in real time for the evaluation of a patient with complex disease, and to identify the best care plan that we think is appropriate for that patient. So that helped us here with moving practices into the new Memorial building. So Memorial West is now that area where we co-locate vascular surgery, cardiac surgery, thoracic surgery, cardiology, and interventional radiology clinics. And I would say, I know Bethany's here, and she shared a lot of that with us, and we've heard great stories from patients that have been able to come in and get more seamless care, I think, as they've gone through this type of an environment. So the next theme I wanted to touch on was how do we manage quality? And one of our most important things that we do, in addition to providing the clinical care, is monitoring our clinical care. So we want to ensure that we're delivering as best a quality, as best a possible outcome at the lowest possible risk for the things that we're managing. And the cardiovascular diseases are challenging because the risks involved from vascular disease are one of the most prominent of all medical conditions. So even today, the number one cause of death is cardiovascular disease and stroke in the population. So we know that identifying problems and effectively treating them improves quality of life and improves quantity of life or mortality. So we want to make sure that we're bringing that in a consistent way, and that all of the providers, physicians, APs, and others are really interacting around quality to make sure that we don't have gaps. So how do we do that? So we're able in an institute model to have a quality management system that spans across all of those specialties. So to use a practical example, I, as an interventional cardiologist, access blood vessels and take pictures of the heart and put stents in the heart. Vascular surgeons do that in the legs and in the neck, and interventional radiologists do that in a lot of their work. And you know, each of us has a complication risk for the work that we do related to the access points, the procedure itself, but there's a lot of overlap. So in an institute, we can take all the specialties and all the work, and we can benchmark that in quality databases and quality dashboards to say, you know, is one area getting more bleeding, or is one area getting more complication risk at their access sites, or is whatever it may be. And those would often be missed in the more traditional model where each specialty was only looking at their own work in isolation. And we're able to develop best practices that span across common types of procedures and services as we look at that quality information and make a judgment about how we would improve. So we've developed that as a formal structure within the Heart and Vascular Institute, so that there are regular meetings to review all of the outcomes of our procedures, and also identify how we can take that information and move it to the individual areas where these procedures or surgeries are done, so that the teams outside of the physicians themselves are also seeing this information and also you know, providing input into a more system approach about how you could improve, rather than just physicians looking at it and identifying what they think they could do better. So it's more inclusive than you typically see in an isolated peer review, you know, more physician-centric environment. So I think that's a plus, and we definitely have learned lessons. Another really important concept in contemporary medicine, but in our area in general, in heart and vascular disease, is data. So we see the traditional data, which is what's in the electronic medical record that interfaces with other medical conditions and other physicians that may treat you as a patient. But we're very data intensive in imaging and in procedural care and diagnostic care. So you know, I can just run down a list of things. In cardiology, we do stress testing and echo imaging and rhythm monitoring and, you know, you name it. And all of these things have to create a flow of data that gets back to the care group that's taking care of that patient in an effective and timely manner, and be part of the decision making. And it has to be available to all the people that are providing vascular care for the patient, so that you can have more of a comprehensive view rather than if I'm just looking at the cardiac cath data and somebody else is doing the echo and somebody else is doing the rhythm. And so that integration of data is helped tremendously by an institute model where we can build systems that create the interfaces to make sure that the data is timely and that the access for the patient for these studies, the wait times are shorter, and that the outputs from the reporting are quicker, and that shortens the length of decision making in the care process for a patient actually pretty significantly. So focusing on how we manage data is a big part of the strategy of an institute model, and it's appropriate for the larger health system as well.
I'm curious, you talk about the institute model, and we've had some other lectures here, some other cardiologists and vascular people come and talk to us about all of the things that are available. Is there something that's not available here? Is there something that I would have to go out of town?
Yeah, that's a great lead-in, because on my next page it's local care. So one of our goals is to be able to provide the best care locally at the level that is appropriate for us to do it. And that is, I think, a big deal in cardiovascular care, because a lot of patients that we treat are older, many are socially isolated, and even traveling to Boston is a big deal, not easy to do, and especially for procedural or surgical care. So we work to make sure that we have a depth of capability, which is procedures, surgical procedures, diagnostics, that is appropriate for the size of our hospital, but also we're making sure we're not missing anything. So to get to your question of what that looks like, I think should look at the world as sort of, primary, secondary, tertiary, and quaternary types of care. So primary types of care are typically ambulatory care around a patient without symptoms. So you have maybe some disease processes like high blood pressure and the like, but you're managed with a primary care provider and maybe some specialist guidance, but you're not actively symptomatic or needing further evaluation. In secondary care, we enter population health, sort of evaluation. So we may say, in the Concord Hospital Health System, we have, let's say, 10,000 patients with diabetes. And we have 8,000 of them that regularly come in and get their labs, but we have 2,000 that don't. So how do we approach the people that either don't have a primary care doctor or are not coming in regularly, and how do we create the outreach and feedback loops to manage those folks? And then tertiary care often is when you're symptomatic and you have a problem and you need to come in either to the hospital or for outpatient evaluation for symptoms. And we're bringing together groups of specialists or inpatient providers that are looking at what's wrong, so how do we figure it out? How do we treat it? And then that encompasses a broad layer of activity for us in the cardiovascular world, which is typically, I'll use an example, you have new chest pain. So if it's bad enough, you come to the ER. We're going through a process to sort that out with labs and testing, and it may lead to an invasive procedure like a heart cath, and it may lead to a stent or a surgery. So at the tertiary level, we're fully capable and equipped to do all of that type of activity for the patient who has symptoms that needs diagnosis and treatment. And that includes some, in our world, more advanced procedures. So I'll name a couple. So transcatheter aortic valve replacement is something that is best done in an institute model with some depth, which we have. Mitral valve clip procedures are very similar. Watchman procedures, which is putting a device in the left atrium so you don't need blood thinner if you have atrial fibrillation, is another one of those procedures. And we are at that level of institute depth where we are doing all of the higher level procedural care and surgical care at the tertiary care level, and probably more advanced than if you were in a traditional model where you had these services just existing, in their own practices. Quaternary care is what you would see if we sent you to Mass General. So some examples of that are, we've done everything and you need a heart transplant evaluation, so we don't do heart transplantation. There are certain types of mechanical support, like left ventricular assist devices, that are better done in a quaternary center. And then there are some, more unusual cardiovascular diseases where we might need a quaternary level specialist in order to get at it, whether they're muscular diseases or high-level rhythm complications that are not really standard for our current electrophysiology service here. So those are going to go to our quaternary referral partners, which here often it's Dartmouth, it's the hospitals in Boston. Those are the most common areas that we have relationships with. And the reason you wouldn't do that type of stuff here is we don't have enough patients that need heart transplants in Concord, New Hampshire to justify a investment in all of the technology and people that could deliver that care. So you do get a pyramid where the quaternary care tends to funnel into, a very small number of more academic centers. But in Concord, we have a highly capable tertiary care cardiovascular institute, which is, I think, bigger than one would expect and more capable for the size of the population of Concord, New Hampshire. So that is for us a regional asset, and it's helped us as we've integrated with Laconia and Franklin, because we now serve with 3 hospitals a market of patients in central New Hampshire, of which more of them in that area are underserved for these types of care than we have here even in Concord. So hopefully that's a long answer and sort of building the model, but did that get at it?
Yeah, that did. I mean, I often in my travels find people who say to me, well, I'm just going to go to Boston if anything's wrong. I really would love for you to tell them that if something happens suddenly, why it may not be a good idea to try to drive down to Boston in terms of time to care and things like that, because people don't necessarily understand that what's being built right here is going to be such that it should take care of that.
Yeah, I think that's a really good point, because all of us, I think, in our mind, when we get sick, we want to go to the best of the best, and that's just natural. And I think that, there's a lot of the best, and if it's designed in a way that I described, you have access locally to what probably represents, 95% of the care that you might need in the cardiovascular space is able to be delivered here at Concord Hospital with the highest quality that you would receive similarly at Mass General or any of those places. So, and that's one of the beauties of the model, is making sure we're very attentive to not overstepping, so that we're not going to try to do something that we don't have the resources to do. But we do want the community to know that you don't have to bypass Concord and go to Boston when you're having X problem. It's certainly a heart attack, you don't want to do that. But, let's say a transcatheter aortic valve replacement or any of the other more advanced vascular procedures, we are fully capable and equivalently skilled as what you would find at large academic centers. another twist to that is there is an unusually, it's not intuitive, but it isn't perfect to go to an academic medical center. Patients can get kind of lost. You know, they provide great care, but academic systems are not as integrated around the patient-first philosophy necessarily as a system that we're trying to build here. So you go for what you need, but it isn't, and I know this from personal experience with my family at Mass General, wonderful care, but many people don't talk to each other, even in the same hospital. So it's just interesting. You know, you get that subspecialized, and you can lose the effect of the institute philosophy.
So what are some of the prevention programs that we have that are associated with cardiac care and vascular care in our community?
The ability to modify risk for vascular disease is really powerful. There are not many things that we deal with in medicine where we in research, not we, but medicine has identified opportunities to improve. So in vascular disease, I'll look at the simple stuff first, which is diet, exercise, and smoking. Those are, you know, three areas that if we increase aerobic exercise, we eliminate smoking, and we optimize diet, I won't go into all of what that is, we can reduce your lifelong cardiovascular risk by maybe 40% or more, even if you start it in middle age, you know. So that's pretty powerful. And then you get into treatment of disease processes that add cardiovascular risk. So the big ones are diabetes and hypertension, and then certain aspects of high cholesterol and types of that. And we have really good data in medical research to show that if you optimally control diabetes and you optimally control high blood pressure and you optimally control your LDL or what we call bad cholesterol level, you can go leaps and bounds over just the lifestyle modifications to reduce vascular risk from those disease processes. So one of the things that we're able to do in an institute and an integrated healthcare delivery system is use data to identify what gaps are for patients. So we can say, you know, not only are we interested in diagnosing your heart and vascular condition and treating it, but we're going to look at the risk factors and identify how do we connect with our primary care colleagues, and in the institute, how do we develop a more focused approach. And one of the ones that we've developed is a smoking cessation clinic. And you know, you'd say, well, that's kind of a no-brainer, but it's hard. You know, I've been doing this for 35 years, and I'm guessing my success rate is maybe 15% at getting my patients to quit smoking. And I deal with the patients that have had the heart attacks that you would think would get the point. So it's an incredibly hard thing to do, and it requires a more longitudinal support process and sometimes medication. And what we're doing in our smoking cessation clinic is developing that support model, not just, oh, yeah, you ought to stop smoking, you had a heart attack, so, you know, that's that. But we're able to get you to people who can provide, you know, the interfaces around, you know, psychologic support for this, because it's a habit. It has a number of other psychological things in your life that have to change in order to successfully quit. And we can get the dietary interfaces, and then we can get the specific tools, whether they be, you know, a medication aid or something like that, that can help you get into the process and the follow-up. So that is unique, and it's not often offered by healthcare systems because it's an investment. You know, it's not something that makes us any money at all. So we're investing in people, and Dr. Joe Meyer was very passionate about this because of his history, long career seeing vascular complications. And he's started this, and I think it's got a great runway. And we can add other approaches that are like that to, say now instead of Dr. Gibb saying, oh, you had a heart attack, you ought to quit smoking, I have a series of people who can support me and amplify that message, and it's right next door in Memorial West. So I think the Institute allows us to do that in more depth than we could otherwise, I guess.
Is that clinic open to teenagers?
Bethany might answer that. I don't know.
I don't think we've seen any teenagers yet, but I think that they would consider it.
Okay, good.
We initially, because to get it up and running, like any approach like this, there's a lot of workflow and, what type of patient do you see first? And it is feed world hunger because still roughly 25% of our population smokes. So, and that's been pretty stable for the last, my career in medicine, interestingly. So, but what we did is look at people who have had vascular disease being seen in our specialties and, feeling like those are the highest risk people we see because they've already had an acute problem, and then enter them as the way that we build the clinic. As we do a more population-focused approach, I think we would open it wider, and teenagers are the natural target because this is, if you can break this in 1 or 2 years after becoming interested in smoking, it's a lot easier than at 20 years into it.
Well, that just kind of leads me to the idea about teens or youth that are overweight and not getting physical exercise. Do you think the Institute will ever play a role relative to prevention in youth, or have some type of something for that?
I think it could, and it doesn't exist today. But if you look at another area that we're developing in the health system is what we term value innovation, which is a integration of our population health activities, quality and safety activities, and the innovation piece is around just that, is how do you create bridges between areas of expertise in healthcare delivery and move it toward the preventative side or improve the workflows? And we do this in diabetes. That's one of the things that we're really working hard on right now. And entering, another aspect of healthcare delivery is, the question, what role does a healthcare system play in social determinants? So these are, things that are what you describe for young people. It's, their exercise, it's their diet, it's how do they access the advice. In other areas, it's poverty plays a role, and where you live and how socially isolated you are plays a role. So how do we connect the dots for what traditionally has been treating sick people to helping prevent illness, by using our resources and our expertise? And that's a really, recently developing concept for health systems, is how do we play that role? And so the connection of, let's say, the Cardiovascular Institute to the Value Innovation Group, which is focused on thinking about that work, is, I think, work to come for us. I don't think it'll just be the Cardiovascular Institute. I think it'll be a lot of our specialty-specific processes need that type of linkage. I'm going to touch on a couple of other points around institute design, and one of those is resource management. And resources includes us as people, which is really the most important ingredient, and then In the cardiovascular worlds, it is a very capital-intensive environment. So we have operating rooms and imaging centers and cath labs and diagnostic equipment that's not cheap, more so than probably any other specialty. And so being able to efficiently manage that environment commonly helps us not duplicate services. So, you know, in the more traditional model, the guys in the cath lab would have their own cath labs. The IR guys would have their own IR lab. The surgeons would have their labs. And we might all be in the same building, but we're not cross-purposing the environments. And that's inefficient for patient scheduling, patient flow, because the technologies are virtually identical between just a room and imaging. But for each of those spaces, we're talking about millions of dollars of investment for just one room. So what we're able to do and have been able to do is develop that conversation with all of the physician specialists that we're able to cross-use our technology. So, you know, I might do a case in the IR lab if the cath lab's not available, or the vascular surgeons might be able to do something that's catheter-based in the cath lab. We're just getting started in that thought process, but as we go forward, that's going to make it more able for us not to buy one of everything for every specialty or two of everything for every specialty. So for Concord Hospital, we can invest that money that we save differently. And that's much harder to do without an institute model where all of the involved physicians are talking to each other about what the common need and the common use is. And then on the people side, I think there's an aspect of an institute that creates an identity. So you have a culture that begins to exist where you're part of a group. You know, the mission becomes more clear of what you're trying to do to take care of the whole group of patients that has vascular disease. And I think, you know, Bethany might speak to this, but, you know, I think there's a little cachet that comes with it that, you know, eventually you want to be part of a team that is all working to do the same thing and feels the same way about what they're doing. So I do think over time we have a recruiting advantage to, you know, recruit nurses and technicians. And again, COVID has made it more challenging, but in a state without COVID, I do think a well-run institute model is attractive to staff to come to work in a health system. And for recruiting physicians and advanced practice providers, I think it's a similar dynamic. If I was a new cardiologist, I think I would want to go to a team where I have access to all the subspecialists that might need to support what I do with patient care, and I've literally got that right across the hall for the most part. So I think as we've recruited a couple of new cardiologists, and now we have actually, I think, 5 vascular surgeons, and including Dr. Meyer. And, you know, when I got here, we didn't have that vascular surgery depth. And, you know, as we've seen younger cardiologists look at the positions that we have open, I think they've expressed, you know, an interest in the model as being one of the draws for their coming to Concord Hospital versus going to Dartmouth or Mass General or Manchester even. So I do think the people side of the equation is a powerful thing, and it just gets better as you do this longer. The last thing. So leadership, the model that we're using is a dyad-based model, so that we are pairing in teams, physicians, administrative leaders, and nursing leaders, so that we're getting, I think, more of a cross-fertilization of opinion and information about how teams do work, how do we design the care, and I think we get better flow of knowledge from physicians into the other portions of our teams about what's coming next, or what needs to happen to improve the workflows. So a lot of that dyad leadership model has, one of the things I like about it is that it keeps you on your toes. You're always needing to manage your own personal growth as a leader, because you're not working in a silo. You're working with a team of many professionals that are all trying to accomplish the best patient care. So as we advance this dyad model, not only in the Heart Institute, but in the health system as a whole, I think it adds value to the patient, because we're getting a more consistent, more common understanding of what the work is and how we do the work and how we improve the work in caring for the patient. So that was the last thing on my list. And we can take more questions now.
I may have missed it. Are you doing bypass
Yes.
surgery?
Yes.
I know there was a time that they were doing it, and then they stopped doing it.
Right.
And then they stopped.
One of the things that had happened about 3 years ago is loss of the one cardiac surgeon that we had here. And one of the issues with having only one cardiac surgeon is it limits how you grow, because that person can only be here for the portion of time that they can. And we can't cover procedures, non-surgical, that needs cardiac surgery backup, so to speak. And we have a harder time managing the acute presentations, where if you came here and you need surgery like that, it's so we have moved to a 2-surgeon, 2 operating room environment over the last year and a half. So we now have 2 staff cardiac surgeons, Dr. Francolencia and Dr. Russo, and we added a second cardiovascular operating room. So we now have 2 fully built out rooms and teams. So we can do 2 cardiac surgeries simultaneously. We can manage the backup needs for the procedural work. And that, in my opinion, was an absolute necessity for us to move to this institute model and grow the rest of our programs.
Okay, I just had one last. I wonder if you're in the mood to share a patient story where you're particularly proud of the outcome or the result. Something that might have been a little bit unexpected, because it was a real challenging situation.
We've had, I'm gonna get a little generic there just because I don't wanna, get into any privacy issues, but we've had a number of those stories from our new relationship in Laconia, and the patients in Laconia, typically when they're acutely ill, they come to what's now Concord Hospital Laconia or Concord Hospital Franklin. And even when I got here a couple of years ago, the ability to connect the dots seamlessly and get those patients transferred here and get the right care was not as seamless as it should be. We've made a lot of efforts to try to improve on that, and I personally I can think of a couple of patients, I still practice in the cath lab, and that have come down that had pretty acute presentations, got their procedure, and we identified some other of these coexisting conditions that in this particular patient had an abdominal aortic aneurysm and had not been able to get an appointment with vascular surgery through the Laconia processes, and knew he had it, knew it probably required surgery, and we were able to connect the dots for that patient while they were here for their heart-related problem, and more or less got that all in play. And just that one ability for that patient, independent of his heart attack, to get his appointment for his aortic aneurysm was so satisfying to him. And I think the heart attack was not top of mind. It was the fact that he could see a vascular surgeon while he was here. So, you know, it may seem like a small thing, but for that particular patient, that was very meaningful. And it helped, I think.
Thank you
All
so
right.
very
Well,
much,
thank
Dr.
you.
Gibb, for your
Yeah,
time.
no, it's
and-
great.
Yeah, and for sharing. And to our audience here, our small audience here, and to our audience out there in our community, we hope you've enjoyed learning about Concord Hospital's Cardiovascular Institute, the expert providers, and the enhanced technology. We're very proud of it and hope you are too, and share the information with your friends and family. Next month in February, What's Up Doc, we will have Dr. Ann Cabot. She will join us, and her topic will be the many faces of multiple sclerosis. On behalf of the entire Concord Hospital Trust team, stay safe, stay healthy, and stay warm.